Welcome to the 2014 course orientation for communication skills for health professionals. My name is Dr. Rick Hess with the College of Pharmacy, and I am pleased to have joining with me during this presentation Dr. Reed Blackwelder from the College of Medicine, Dr. Chris Dula from the College of Arts and Sciences, and Dr. Sue Grover from the College of Nursing. This is a very unique course in which you're about to begin. It is, to our knowledge, the largest required communications course in the nation. And due to the size of the class and due to the spacing logistics that we have, this is really the best way we feel to orient all students to the course prior to starting meeting in their small groups. Therefore, the objectives for this short webinar orientation is to, number one, review the syllabus and the course logistics. Secondly, we want to at least introduce to you the concept of the importance of communications, both from a clinician-patient relationship, which we will also refer to as interpersonal communication, as well as interprofessional communication. We also want to introduce to you a patient-centered process of interviewing. This is really the heart of the course. And then finally, I want to at least introduce you to the idea of what a small skills group is and what standardized patients are and how they will be relating to you in your small groups. This slide is just to give you an idea of the breakdown of all the students that are enrolled in this particular course. And this pie chart shows you that the majority of students are pharmacy and medicine students. This course, again, is very large, encompassing approximately 200 students total and 30 faculty representatives from all the colleges, as well as standardized patients, which we'll talk about a little bit more later in this presentation. Now that I've given you a little bit of an idea of who is all enrolled in the course, I want to shift the focus now to the course structure and the assignments of the course itself. The best way to describe this course is that it is a blended learning course, which simply means there'll be some self-directed, computer-based, interactive modules that you will be required to watch prior to meeting with your small skills group. These modules will really focus on several areas of communication. Number one, of course, the core skills, which is the heart of the course. There will be modules on how to build rapport with patients. There'll be modules on setting the agenda of an interview. Modules on information management, active listening, addressing feelings, reaching common ground, and closing the interview. These modules represent the core skills of interpersonal communication. You will spend the majority of your semester focusing in on these core skills. Now, the module themselves are PowerPoint presentations of anywhere from about 30 to 40 slides containing information, as well as examples of small videos of showing or illustrating good and bad interviewing techniques. In addition to the core skills modules, you will be required to complete a few special modules as well. One on health literacy, one on learning how to break bad news, and there'll be 2 mini interprofessional communication modules. At the end of each module, required module that you will be asked to complete, there will be a short quiz which will be required it has to be completed prior to your small skills group meeting. The majority of the quizzes are made up of 4 multiple choice questions. And these answers, or the quizzes, will be completed online on D2L, the Desire to Learn platform. On the first day of your small skills group, you will also receive a CD-ROM containing all of these PowerPoint presentations, all of these modules, required modules, the core skills modules, as well as the special modules that will be required for the course. And in addition to that, on the CD-ROM, there will be some advanced communication skills modules. One is on family interviewing, one is on sexual history taking, and one is on intimate partner violence. These three advanced skills modules will not be required for this particular course, but you may find them helpful later on as you go through your respective programs. So in essence, the CD-ROM that you'll be receiving is kind of like the textbook for the course that you can use or refer to later on. So as I described this course as a blended learning course, there is a self-directed, computer-based interactive modules which you will be required to complete prior to meeting in your small skills group. Now your small skills group will be meeting every other week, and your small skills group is going to be comprised of students from the College of Pharmacy, the College of Nursing, the College of Medicine, and perhaps even graduate psychology students from the College of Arts and Sciences. In your small skills group, you will have the opportunity to interview 2 to 3 standardized patients each time you meet together. In your small skills group, this is where you really get to practice what you learned in your modules. Really, the best way to perfect interpersonal communication and interviewing skills is to actually practice interviewing yourself. And this course gives you ample opportunities to practice your interviewing skills utilizing standardized patients. As I said earlier, there's really 2 ways of communication that we want to emphasize in this course. One is, of course, interpersonal communication. That is the relationship, the communication between a patient and the provider. But we also are going to have opportunities to have interprofessional communication discussions. As future healthcare professionals, it's not only important to know how to communicate effectively with your patients, but it's also important to know how to effectively communicate with your colleagues as well. So there will be 2 opportunities throughout the semester to have interprofessional discussions among your small skills group. Your participation in these interprofessional discussions will be graded by your small skills group faculty member. And finally, objective structural clinical evaluations, or OSCEs as we refer to them as. You will have a midterm OSCE and you will have a final OSCE. And basically, an OSCE is going to be an 8-minute interview with a standardized patient, or SP, that is uninterrupted with you and only the standardized patient. And this interview will be viewed and graded by a faculty member. So to summarize, there are several ways in which you will be graded in this course. Number 1, you'll be graded on your performance on the module quizzes, and each of the required modules will have a short quiz at the end. Secondly, you'll be graded also by your faculty small skills group leader on your participation in the interprofessional discussions. And you will thirdly be graded on your OSCE performances on your midterm as well as your final. And I'll show you the breakdown of how those grades are assigned here in just a minute. Each year, a group of faculty will sit down and review the course and review all of the comments and feedback that's been provided by the students. At the end of each module that you will complete online, a short feedback area will be provided for each student to write in comments. What did they like and dislike about that particular module? And the faculty that meet and review this take these comments very seriously. So I wanted to give you an update on some of the course changes that we've made for the 2014 course that's really based off of some of the comments from students. Number one is we've revised the modules, and we have also revised some of the multiple choice questions or quizzes at the end of the modules. For example, we may have rewritten a question to make the question more clear to the student learner, or we may have changed the answer so that the answer is more clear to the student learner. In addition, if a question is answered incorrectly, you can click on the feedback icon and get immediate feedback, or at least the rationale or an explanation as to why that your choice was incorrect. One module in particular, which has undergone a extensive revision, is the interprofessional communication module. This module, based on student feedback, has been expanded, and new videos have been added that should hopefully instruct the student on the proper ways of interprofessional communication. And finally, something else that we are doing different this year, and this isn't necessarily based on student feedback, but more program logistics, is that we are recording all of the midterm OSCEs earlier in the semester and uploading the videos of those onto a YouTube format that will only be accessible to the faculty member who is responsible for reviewing your midterm OSCE. Don't fret, don't get upset. These YouTube links and videos are not searchable, so you don't have to worry about your friends or family members Googling your name in midterm OSCE and finding any hits. I want to take a few minutes to review the course schedule, make sure that everybody understands it. Everybody will be divided up either into a Group A or a Group B. So one of the first things that you should be clear about is, are you meeting in Group A or are you meeting in Group B? And to find the answer to that, it should be, if it's not posted already on the D2L, it will be posted very, very shortly. So when you look at the far left column and you see dates there, and you see either the letter A or the letter B listed to the right of it, that tells you, if you're in Group A, which day you're meeting in your small group, or if you're in Group B, which date you're meeting in your small group. For example, if you look at August 28th, and you see right there, right to the right of it is the letter A. That means that if you're assigned to Group A, you will be meeting with your small group on that Thursday, August the 28th. However, if you are assigned to Group B, you will not be meeting with your small group on August the 28th, yet you will meet with your group on September the 4th. And so this alternating pattern of Group A and Group B follows all through the semester with a couple of important exceptions. And these exceptions occur during the midterm OSCE recording. If you look on October the 3rd, which is actually a Friday and not a Thursday, all the medical students that afternoon will be assigned to a specific 8-minute interview time that he or she will record their midterm OSCE. Subsequently, the following week, on Thursday, on October the 9th, pharmacy students, nursing students, and psychology students will all be scheduled to take their midterm OSCE recording. Pharmacy students will be scheduled in the morning during their exam block, and nursing and psychology students will be scheduled in the afternoon. These dates and times and postings and all will be well communicated to you via email and D2L as the time gets closer. I want to have you go back up to near the top of this schedule and look under the column that says modules and quiz due dates. If you see here listed, for example, on August the 28th for Group A or September the 4th for Group B, you'll see that rapport, agenda setting, and information management modules and quizzes will be due prior to you meeting with your small skills group. Now the quizzes that are due will be completed online via D2L. And again, I want to emphasize these quizzes must be completed prior to meeting in your small skills group. If you look at the far right column, where it's labeled Small Skills Group Activities, you'll see some introductions and housekeeping items there. You'll see standardized patient cases. The names of the cases really are not relevant to you. Those are just telling you which cases are going to be portrayed by the standardized patients on that particular day. So the take-home message to this particular calendar is this. Number one, you need to know which group you're in. Are you in Group A or are you in Group B? Because that's going to determine which day you're meeting in your small skills group. And number two, you need to know which of the module quizzes are due prior to meeting in your small skills group. And again, these quizzes for the modules must be completed prior to you attending your small skills group. Now this slide gives us a little picture of how the course is going to be graded and how these assignments are weighted. First of all, you see here the midterm OSCE is going to count 15% of your final grade. The midterm OSCE again is going to be an 8-minute recorded interview that you will have with a standardized patient that will be watched and graded by your small skills group faculty member. All of this small skills group participation, your interprofessional communication discussions, remember those are going to be 2 evaluations that are be completed by your faculty member over the semester, and they account for 20% of your final grade. All the module quizzes, again, that will be completed on D2L, make up 15% of your grade. And then your final OSCE is going to consist of really 2 live interviews, which will be made up, will make up 50% of your final grade. Communications, as I said, is something that you should improve upon with more and more practice. And the faculty feel in this course that your best interviews really should be your last interviews. And so that is the reason why the final OSCE is weighted 50% of your grade, as these will be the final 2 interviews of the semester. And now to look at the course grading. Since there are 4 colleges represented in this course, there are 4 different grading scales. And so now I'm going to allow the other course coordinators to briefly describe their course grading.
One of the most important things in terms of the grading for the College of Medicine students is that this is a pass-fail course. So I want you to realize that we're not going to have a specific grade and that pretty much everybody passes, which is a good thing. However, I don't want you to really look at this course as a grade course. Because it's pass-fail, you're going to get to focus on the skills, which is truly the most important part of the communications course. I hope that you'll be listening for the feedback that you get, the verbal feedback that you get during the groups from your peers, from your faculty facilitator, and even during the one-on-one sessions that you'll get with some of the midterms. Also, I hope to be providing some written feedback at different times for hopefully all of the medical students. So when you look at the pass-fail numbers, 7 to 100 is passing, and that's readily done. I don't think anyone has failed this course in the College of Medicine. And if you are having issues, you're going to hear about it. And it won't be because of a grade. It's going to be because some of these skills need a little additional work. And our job is to help you really have these as core skills that you can take forward.
Welcome, nursing students, to what we anticipate will be a great course for you. You're fortunate in that it is an interprofessional course, so you will be taking this with medical students, pharmacy students, and psychology students. Because there are so many different professional students taking the course, you can see that there are different grading scales. In nursing, our accreditation requires that we give a grade to each nursing course. And actually, this will really help you in the long run, because when you apply for your master's program, or if you decide to continue on in nursing, you'll be able to use the grade to help you with your GPA. So that's why we are required to give a grade for this course. As with all of your nursing courses, the lowest grade that you can get in any nursing course is a C. So therefore, you will need to get at least a 75. I don't have any concerns that each of you will get much higher than a 75. So welcome, and that's why we have different course grades. If you have any issues at all with the course, with your grades whatsoever, please give me a call at any time or email me.
Psychology students will find their grades ranging from A to C on a 70 to 100 scale, as are found in their other courses in our program. Our course is actually reflective of hybrid, where half the time they are in a traditional interviewing techniques course with me, and the other half the time they're with the small groups in the CSHP course. So that's unique, and it's amazingly cool for us in terms of interprofessional development and skills development as well, because they get to practice with the standardized patients and interact with the small groups and their peers, as well as do the traditional readings and practice that they would receive in the other part of the course. So their grade is derived from the scores they receive in the CSHP course, as well as the scores they get in the regular course, which are combined to derive their final score.
Next, I want to go over a few course policies. First, the dress policy. Since you're going to be interviewing standardized patients in your small skills group, please wear clothing that is respectful for your patients, your standardized patients, and members of your small skills group. Course faculty will have the right to dismiss any student or students from his or her skills group if student dress is a distraction to the faculty, to the other students, or to the SP. And any dismissed students will be required to make up that missed small skills group. Now, for purposes of the OSCEs, we request that you dress professionally. That does not necessarily mean that you have to wear a white coat. That is acceptable, but not required. On missing any quizzes or late quizzes, remember each module is going to have a D2L quiz assigned to it. All quizzes are due prior to meeting in your small skills group. So unless there is prior approval or an excused absence that is approved by either myself or the other course coordinators in each respective discipline, any late quizzes will be assigned a grade of 0. It will not be accepted. As far as missing your small skills group, remember, these groups are meeting every other week, so you really only have about 5 to 6 small skills group meetings. So if you anticipate and you know in advance that you're going to miss a small skills group, please let us know as soon as possible. What we typically do in that example is that we will assign you or reassign you to another group for that particular session. So let's say you're in group A and you know that you're going to miss a group. We'll assign you to a group B for that particular week. If a unanticipated emergency occurs, though, you'll either be assigned to an alternate group, if possible, or you'll be assigned an out-of-class remedial assignment. And we give you one time. You can miss one small skills group. After that, if you miss 2 or more, regardless if it's excused or not, your grade will be reduced by 10% per missed session. Again, I can't emphasize enough how important it is to practice and to get practice interviewing with standardized patients. And without that practice, your grade will likely be compromised on the OSCEs. Speaking of OSCEs, if for any unseen reason that an OSCE is missed, if it's acknowledged and excused by one of the course coordinators, that OSCE will have to be rescheduled as soon as possible. Given the logistics and the challenges of scheduling the OSCEs with standardized patients, excused absences will often result in a delay of grades, or maybe possibly even an incomplete grade assigned to you until the OSCEs are finished. And then finally, academic misconduct. Since there's two groups meeting on alternate weeks, D2L quizzes and OSCEs are going to be on different days and even different weeks. And any allegations of academic misconduct that is reported will be investigated and taken very seriously. And it will be handled by the dean's office in the college with where the alleged misconduct occurred in that student's discipline. One thing I just want to emphasize, or at least introduce to you right now, and this will be emphasized over the semester, is that this course is not about your clinical and therapeutic knowledge. As first-year students in a professional program, you will not have the skills or the knowledge, the clinical knowledge, to make good clinical decisions. You're not being asked you're not going to be graded on whether or not you know how to appropriately treat diabetes or how to appropriately treat a particular disease. So really what we're looking for is, how do you interview the patient? Is your patient interviewing taking a patient-centered approach? And that is really what we're highlighting, and that's really what we're focusing on. Not that you can diagnose patients, and not that you know the medications that have to be used for a particular condition. So unlike probably all the other courses that you're going to take at your college, this particular course, we don't care about your clinical knowledge, but we do care about your interpersonal and interprofessional communication, and to really excel in those in that method of communication. You just have to be able to listen to a patient and relate to a patient. You don't have to have the clinical and therapeutic knowledge to make those decisions. So again, I just want to emphasize that now, and it will be emphasized over the semester. This is not about your clinical knowledge. This is not about your clinical decision making. This is all about how can you communicate with the patient. Again, I want to bring back some of my colleagues here just to spend a couple of minutes to briefly discuss with you why communication is so important, really from a discipline-specific perspective.
As I told the first-year students at a recent class session on professionalism, the communication skills are really a core skill. This is one of the most important things, if not the most important skill, that I think anyone should have, especially anyone in the healthcare professions. This has a lot of different places for utility. This is really about time management. It's about diagnostic skills. It's about the way of getting through the patient interview and getting the information that you need. However, what's really important is that this is not about trying to figure out an answer or a diagnosis at this stage. Especially with this course, as we're moving forward in the first year, it's really about how to develop your bedside manner. It's about how do you interact with patients in a way that really allows them to share their ideas with you, that you will learn how to appreciate their perspective of what's going on, and that really lets you focus your discussions during the interview, but also ultimately the plans as you get more and more along your path of learning how to be a physician. Some of the skills that we don't specifically talk about in the course, but that I use as a way of adding to the communication core skills, is something called ask, tell, ask. And what that means is, before you say things, because you really want to tell people something, especially if you're starting to get some knowledge and you think you know it, what you want to do first, though, is ask. Ask somebody what they know about a particular problem. And you will be able to use this tool in the communication sessions. Once you hear what they need to know, then you can tell them that specifically. And then you ask again to see what they heard. And these are really good questions to include in what you're learning in the communication skills. Ultimately, communication skills is the tool that you will always have. You'll want to use it in the best way possible, especially in terms of your patients. I'm still honing these skills myself, and I'm still learning from the sessions that I have with each of you. Each of you will approach things in a way very different than anyone else, and it will work for you. You're going to find your style and your process. But I'm still planning to find a great question or a new approach that I haven't used before, and that happens every year. Ultimately, what this is about is a life skill. This is not just a clinical skill. It's not something you're just going to use in this course for one semester. I really encourage you to see this as something that truly will help you as you move forward in your life as well as your profession. It's useful with patients, with peers, with staff, with supervisors, with friends, and with family. In fact, the most frustrating thing about this is we'll be really good working with a patient, and then we'll go home and have something come up, a strong emotional issue, and instead of recognizing and responding to emotion as we'll teach you in this course, we'll respond, draw a line in the sand, and get defensive. And you'll learn pretty quickly that you really wish you'd use these communication skills as we had taught them. So to summarize, this is truly the most important skill that you're going to get as a health professional. Everything else that you get adds to this. If you do this well, you'll have outstanding bedside manner, you'll be able to connect, you'll be able to utilize your time properly, you'll be able to help give good care to your patients. Our job is to help you get there. I look forward to working with you on that.
Greetings again, nursing students. We approach this course from the framework that communication is a skill that you learn. Just how you are going to learn how to start an IV, how to give an injection, how to develop nursing diagnoses and care plans, you have to learn certain therapeutic nursing skills. Talking about therapeutic communication skills means that you will be learning in this course how to hear the patient's message, how to listen, how to respond, and how to develop a mutually agreed upon care plan or an intervention. I want to emphasize that you do not need to know anything about medical diagnoses at all. We are going to concentrate solely on the communication skill. How you use open-ended questions to get patients to talk. How you try to hear the patient's story, etc. You do not need to know anything about diabetes or heart problems or anything. So don't get caught up in saying or thinking that you have to know everything about a particular diagnosis in order to respond. You do not. So we will focus on asking questions and responding to the patient based on key communication skills. These are things like how to do open-ended questions, how to respond to patients, how to use silence, how to reach common ground, etc. All of these are the key skills that you will learn in this course. As a nurse, you will probably be the first person a patient meets in the healthcare system. How you listen and respond to the patient can set the stage for patient satisfaction, patient compliance, as well as positive healthcare outcomes. Many times you as a nurse will see the patient after a medical diagnosis has been made. For many patients, there's a lot of denial initially. So you may be the one to work with that patient on understanding the diagnosis and assessing how much the patient knows about that. Caring is the heart of nursing. So in that concept of caring is communication, because that's how the patient will feel that you really care about him or her. We'll be focusing on developing empathy, developing listening and hearing skills, and the skills to develop a mutually agreed upon care plan. You will do this within the context of an interprofessional setting, so that in your small group setting there will be definitely medical students, possibly psychology student, and a pharmacy student. So you'll begin to learn the roles of different professionals in the healthcare system. And you'll begin to share what you are learning about nursing with those other folks. So welcome again to this course. And if you have any questions, again, please feel free to email me.
Communication is at the heart of psychology on so many levels. One level where communication is important is in dispelling myths of mental illness. Mind-body dualism is a concept that's been around since the pre-Socratic philosophers, but it was most heavily popularized by Descartes. In this view, the mind and body are somehow inherently separate from one another, and this drove the development of two parallel systems, one for physical health care and one for mental health care. In fact, it wasn't until the 20th century before we had any real recognition of mental health as a legitimate issue. In the early 20th century, talk therapies were developed, and many contained ineffective components. But over time, such therapies have been subjected to serious research scrutiny such that those trained in graduate programs today and those who obtain state licensure as mental health care providers are armed with very effective techniques for helping many patients to effect positive change in their lives. Communication is also at the heart of talk therapy techniques, but talk therapy is more than just talk. It also includes both cognitive and behavioral change techniques, and the most ubiquitous and broadly effective mode of therapy is called cognitive behavioral therapy, or CBT. Psychologists are rigorously trained in diagnostics and treatment, and moreover they're also trained as scientists to investigate such things as epidemiology, diagnostic approaches, the efficacy of therapies, as well as to investigate the causes and maintenance factors involved in mental health issues. Due to this type of work, we know that for many issues, such as depression, the best outcomes are achieved through a combination of medicine and talk therapy. Medication, when used alone, has a pretty good efficacy rate, but it has a fairly high rate of relapse upon discontinuation. And talk therapy used alone also has a similar efficacy rate, but it has a lower incidence of relapse when it's terminated. But by combining medication and talk therapy, it appears that medications help abate symptoms such as lethargy and apathy, and that helps to motivate patients to make maximal use of talk therapy, through which they work to change their lives in terms of their automatic cognitions, behavioral habits, and personal relationships. And these types of life issues are seen regularly in medical settings. It's been estimated that between 50 to 70% of primary care patients have no identifiable physical ailments. So likely these are symptoms of stress, psychosomatic complaints, or simply worries about one's health. Primary care physicians make note of mental health issues in up to half of all visits and prescribe about 85% of all psychiatric medication. Yet between 50 and 80% of all mental health conditions are either missed or misdiagnosed. Referrals are few, with only 5% of all mental health referrals coming from primary care physicians. But of those referred to mental health care, up to 70% do not actually follow through. It's believed that at least 30% of patients can benefit from psychosocial interventions, and we are developing brief interventions for a wide variety of problems. Many therapy approaches no longer adhere to the traditional 50-minute session once per week model. In newer modes of healthcare, we function as consultants to members of the healthcare team and are especially helpful when they're overwhelmed by difficult patients, also known as heart sink patients, which you'll read about in the CSHP materials. Clinical psychologists have been represented in family medicine as an integral part of residency programs for many years, and were especially effective in assisting with adjunctive care and behavioral changes pertaining to health risks and treatment adherence. It's one thing to recommend to patients that they eat a sensible diet, stop smoking, refrain from excessive alcohol use, get plenty of sleep, get plenty of exercise, etc., and another thing else entirely to help them accomplish these behavioral goals. Psychology specializes in helping patients accomplish positive behavior change. Because much of the health of an individual depends on their emotional condition, attitudes and beliefs, and behavior, it turns out that psychology has much more to offer than just mental health care. We can work with other healthcare providers to assist with a wide range of medical issues. In diagnosis, we actually have 5 axes in the DSM, one of which is general medical conditions, and another of which is psychosocial stressors. And that reflects the recognition of an inherent mind-body monism, or what many term as a holistic approach to health. If you look at the top 10 causes of death over the past couple of decades, you'll find in addition to microbial and toxic agents, which account for less than 10% of deaths, such issues as tobacco use, diet, lack of physical activity, alcohol use, firearms, sexual behavior, motor vehicle crashes, and illicit drug use account for about 40% of all causes of death. In the latter group, one can clearly see, in addition to some potential genetic or familial risk factors, that almost all of these causes of death have significant behavioral components, which, if attended to diligently, would dramatically reduce our collective mortality risk. But even in cases of infection or poison, behavioral precautions would obviously be helpful in reducing risk. Again, behavior change is a specialty of psychology, so behavioral health risks can be addressed with the specific help of scientifically based psychological approaches to healthcare, including effective communication. Our doctoral program trains scientist practitioners, and we engage in what we call primary care psychology, which aims to put therapists in primary care settings, because that's where patients typically go for mental health care assistance. But it's where we can also be of assistance to other healthcare providers in helping to ameliorate risk and enhance treatment of many types of physical health issues as well. We've been a part of the CSHP course for a number of years now, and we're most pleased to be included and have the opportunity to work with our professional colleagues across the healthcare spectrum. Again, communication is the heart of what we do, and interprofessional communication is as important as any type of communication. So please keep in mind that our students are relatively new to our program, as they joined the CSHP course in the first semester here at ETSU. But we hope that they'll be excellent diplomatic representatives of our discipline, and we hope you'll enjoy working with them. And we thank you for your time and attention and the inclusion of psychology in the overall health care of all of our patients.
Now, with pharmacy, of course, we're focused on medicines and we're focused on drugs. However, these drugs do not work very well if a patient doesn't understand how to take them correctly or doesn't understand how to use them correctly. And so the importance of communication from an interpersonal perspective is extremely important in pharmacy. Pharmacists have to counsel patients by law, and patients need to understand what it is they're taking, why they're taking it, what can they expect from it, how is it going to help them. These are all extremely important concepts that patients have to understand, and the pharmacist is in the front line to communicate that to patients. Interestingly, from a historical perspective, the American Pharmacists Association, back in 1952, in their Code of Ethics, actually says that pharmacists should not talk to patients at all. That if they had a question about anything, they would be referred back to the prescriber. Now, of course, to put it into context, back in the early 50s, the focus was really about the business aspect of pharmacy and not so much the patient. But, of course, this is not the same now. It has changed, whereas pharmacy is a patient-centered business. Now, in regards to interprofessional communication with the Affordable Care Act and the advent of accountable care organizations and patient-centered medical home models, where pharmacists are increasingly being involved. They're at the table with physicians and nurses and social workers and clinical psychologists. Now, we've used the term a couple of times during this webinar saying a patient-centered approach or a patient-centered interviewing. And I wanted just to give you a quick introduction of what it is that we're really talking about. When we say patient-centered interviewing, what we're talking about is really understanding the patient's ideas about their diagnosis or their medications, or what is their greatest concerns, or what is their expectations. And in order to understand the patient's ideas, you have to hear them. You have to be listening for them, and that's one of the skills that we're going to be teaching you. You have to be able to still collect data in order to make a clinical diagnosis or recommendation. Now, again, I'm speaking of as you matriculate through your programs. Again, in this particular course, we're not collecting data for diagnosing. We're not collecting data to make a firm recommendation. What we're doing is we're practicing the patient-centered interviewing skills. But when you go through your program and as you gain clinical knowledge and as you gain that experience, you will have to learn how to balance both understanding and hearing the patient's ideas and concerns, as at the same time you're collecting data to make an educated decision. All right. So, and we're also talking about how do you reach common ground with the patient by addressing their perspective while at the same time giving your professional assessment and recommendation. And it's really a balancing act, and it's a skill that takes practice and will be learned. Here's a schematic that shows a traditional interview. And by traditional interview, what I'm really saying is a clinician-centered interview, not a patient-centered interview. And the traditional interview basically is a conversation. Well, you could even say that it's maybe not really a conversation. It's an interview where the clinician is basically asking all the questions, typically closed-ended questions that are yes to no answers, and oftentimes in rapid sequence. If you notice here, there's lots of information that needs to be gathered. You still have to listen about patient symptoms, timeline, modifying factors, associated symptoms. There has to be an educated decision and an assessment and a plan, basically, a recommendation that's put into place. But notice in this particular schematic that there's nothing in here about what the patient's ideas or the patient's concerns or the patient's expectations at all. It's totally absent. And so to contrast the traditional clinician-centered interview approach, here's what we're trying to teach you. We're trying to teach you a patient-centered approach where you still have a diagnostic or a clinical perspective. All right, you still have to, collect information about symptoms and timelines and factors and associated symptoms. But at the same time, notice that there is an illness perspective that the patient is going to provide as well. What is the patient's ideas for causation of the problem? What is the emotions that are tied to it? What are their expectations about it? What kind of impact is it having on them? And this is what we're trying to teach you, is how do you balance both the diagnostic clinician perspective with a patient perspective of their illness. So if you were to diagram what we're expecting you to do in your interview, or put together a schematic of what your final OSCE interview would look like, it would look like something like this. As you can tell, this is very convoluted and it goes in and out. It's not linear. It's not like the traditional interview. It's not one way. As you can tell from this, if you can, there is a clinician perspective. There's a diagnostic hypothesis. But at the same time, you're listening for symptoms. You're listening for patient clues. You're actively listening to see what is the patient's perspective of their illness. And it's kind of weaving back and forth between a diagnostic or clinician-centered perspective, and also at the same time balancing that with the patient-centered perspective as well. And as the interview goes on down, you begin making an impression or an assessment. But at the same time, you got to, what is the patient's expectations? What are their compelling needs? And are you able to reach common ground? There'll be SP scenarios where you're wanting an SP to make a behavior change and they're not willing to do it. So how do you reach common ground in cases like that? And so as you can see through this process, there's lots of weaving in and out between the clinician decision making and as also the patient perspective as well. And this is a skill that takes practice. This is a skill that can be learned at the same time. And really what you're trying to do is you're trying to connect the two worlds together. So again, the heart of this course is on interpersonal communication. And it's really built upon these 7 modules that you will be asked to review and complete. And you'll have plenty of opportunities over the semester to interview standardized patients and practice each of these core skills. The standardized patients, or SPs, are really the unsung heroes of this particular course. Practicing your interviewing skills, utilizing the SPs dramatically improves your communication skills without question. And it's been shown that the practice really, really improves the learning. So, what does a small group practice session look like? What can you expect when you meet in your small skills group? Well, one of the things is that you can be expected to receive feedback on your interviewing skills, not only by your faculty member, but also by your peers. Your small skills group is going to be made up of anywhere from 6 to 8 students from different backgrounds, from different disciplines. And they will also be watching you interview in your small skills group and will be able to provide you some valuable constructive feedback. There'll also be times of self-reflection. I often ask my students in the small skills group after they've completed an interview is, well, tell me how you felt it went. What did you feel you did best? What do you feel that you really struggled with? So self-reflection will also be a part of your small skills group. Some faculty will allow timeouts. So what that means is if you're in the middle of an interview with an SP, the faculty member may call timeout in the middle of your interview. And it's not to say that maybe you've done something wrong, but maybe a lot of stuff has transpired that it would be a good opportunity to kind of talk about it and debrief with your small skills group. Some faculty allow the student who's interviewing to call timeout. So if you sit down, especially that first day, and you sit down with your first SP patient, it might be 10 seconds or 15 seconds into the interview before you call timeout because you don't know where to go next. I mean, that's okay. Your faculty member who leads your small skills group on the first day will set housekeeping rules and set ground rules. Some allow timeouts and some don't, but both ways are effective at learning. And finally, we wanted to give you some resources for troubleshooting if you have any problems. For example, if you're having any technology problems or computer issues, please contact Sam. If you're having questions about small group scheduling, that'll be Vanessa Cantor would be the one to contact. Like, so for example, if you know you're going to have a schedule conflict with one of your meetings, your smallest group meetings, please let Vanessa know as soon as possible. She will be the one responsible for rescheduling you. If you have any questions about grading or any other course issues, please contact your discipline-specific course coordinator. Now that you've completed this course orientation module, there's some very key questions that you need to be able to answer to know if you're ready to start in the course. Prior to that, though, I want to encourage you to review the syllabus. We've highlighted several key components of the syllabus in this orientation. However, I would encourage you to download it from D2L and take a brief look at it to make sure that you're very clear and understanding on the course policies, how the course is structured, how the course is graded, and please let us know if you have any questions whatsoever. So, to know if you're ready or not, number one, when does your small skills group meet? Does it meet in Group A or does it meet in Group B? That's very important to know. Secondly, where does your group meet? There's 21 groups that meet at the same time, and they're spread out all over the VA campus. Please look at and find your small skills group and find where it meets. If you do not know, please let us know. On D2L, there is a VA campus map that you can also download to find which building and to find where your small skills group is meeting. Thirdly, when is your first module quizzes due? Remember, those are going to be due prior to meeting with your small skills group. So knowing if you're Group A or Group B, very important. It will also determine when your first quiz is due. Next, what is an OSCE and how does it affect my grade? We talked a little bit about OSCEs and how it's an uninterrupted 8-minute interview that will be weighed very heavily. 65% of your total grade in this course is going to be based off of 3 interviews. 1 for the midterm OSCE and 2 for the final OSCE. And finally, how does a patient-centered interview differ from a traditional clinician-centered interview? This will be something that we've introduced to you, or is something we've introduced to you in this particular orientation, and it's something that we hope will become very clear to you as you progress through this particular course. Again, it is our pleasure, it is our honor to have you with us, and if we can be of any assistance, please let us know, and we will look forward to you enjoying this course.